Namaste friends, welcome back to ICU with Dr. Bhautik. Today we will are discussing one of the most life-saving intervention in severe ARDS, prone ventilation. Many clinicians think proning only improve the oxygenation, but actually the prone position improve the oxygenation, reduce ventilator-induced lung injury, and most important, reduced mortality. By end of this lecture, we will know why the prone position work, when it used, how to do it safely, and what complication to watch for. Let's begin. In ARDS, patient become the hypoxemic. All right, why? In ARDS, alveoli fill with fluid, lung compliance decrease, dependent lung region is collapsed. So when the patient lays supine, heart and abdominal content compress the posterior lung. This does the dorsal alveoli collapse. The result is increased shunt, poor VQ matching, and severe hypoxemia. Although the posterior lung contains the most of the lung tissue, there is the poor ventilation. This is where the prone ventilation position helps. What happening during the prone position? Like when the patient is turning to prone, the dorsal lung become non-dependent. Compression is decreased, collapse alveoli reopened, and ventilation becomes more uniform. The benefit includes improved ventilatory perfusion matching, VQ matching is improved alveolar recruitment, reduced shunt, improved oxygenation, reduced over distension in the ventilator alveoli, and reduced ventilator-induced lung injury. So, proning is not so simple about the increasing oxygen as is protect the lung also. Evidence behind the proning landmark is ProSeva trial shows patient with the severe ARDS who were prone early for at least 16 hours a day had significantly lower the mortality. Mortality reduction was dramatical. This changed ARDS management worldwide. Today, the prone position is standard care for the severe ARDS. Then, what are the indications? Stronger indication is PaO2 F1, FiO2 is less than 150, despite the P greater than 5 and FiO2 greater than 60% requirement, especially if the moderate ARDS is severe or refractory hypoxemia patients. Best results occur when the proning is started early, preferably within the 24 to 48 hours. Contraindication: the proning may not be suitable in the unstable pain injury, open chest, open abdomen, uncontrolled shock, severe arrhythmia, unstable fracture, recent major facial surgery. Many contraindications are relatively rather than the absolute. Always assess the risk versus benefits. Now come to the physiology. What are the physiological benefits? Why does the oxygenation improves? Better VQ matching, ventilation become the more evenly distributed, and perfusion remains the good, and gas exchange improves. More alveoli recruit. Second is more alveoli recruit. Collapse. Posterior alveoli reopen. Functional lung volume is increase. Third is reduce lung stress. Stress is distributed evenly. Less over distension and less ventilatory associated lung injury. Fourth is improve secretion drainage. Secretions move more effectively. Risk of mucus plugging is decreased. Then how to do prone position step by step way. It's usually required 5 to 6 peoples before the proning. Check for the indication confirmed, airway secure, ET tube fixation is checked, central line is secure, arterial line is secure, feeding is paused, suction is confirmed, and FiO2 increase temporarily. Now turning procedure is like use the leg rolls. Okay, maintain the cervical alignment, protect the whole line in tube, turn patient in block, avoid twisting, and communication is critical in this procedure. So one person should lead the entire procedure. Position in the prone. The important positioning point, like head should be neutral, arm in swimmer's position, and pillow under the chest and pelvic region, and abdomen should be free. This prevent the increase in intra-abdominal pressure and protect the eye carefully, protect the pressure point carefully, and ensure the endotracheal tube remain in the secure position. Now come to the ventilatory part. Ventilator management. Continue the lung protection ventilation, like tidal volume 4 to 6 ml per kg, plateau pressure less than 30, driving pressure less than 15. Maintain appropriate prep. Permissive hypercapnia if acceptable if needed, and check for the ABG after proning. What improvements should be expected? ठीक है, usually within 1 to 2 hour, PaO2 increase, PaO2 FiO2 ratio increase, compliance increase, driving pressure reduce. You can check immediately for the, if the oxygenation is worse, then check for the tube replacement, pneumothorax secretion, and hemodynamic instability. Then now come to the duration and frequency. Proning for the 16 hour a day. Do not stop too early. Continuous daily season until the PO2 FiO2 ratio improved 150 to 200 with FiO2 and lower PEEP requirement. What are the complications now? Pressure sore, facial injury, eye injury, corneal abrasion, tube displacement, line displacement, brachial injury, and hemodynamic instability. Most of the complications are preventable and with the proper preparation. Practical ICU pulse checklist. Like, remember these golden rules: prone early, prone long, at least 16 hour, combined with a long lung protection ventilation. Use the adequate PEEP. Monitor oxygenation and driving pressure, and trim work is essential. Prevention of the complication is important as the procedure itself. Now come to the take home message. In severe ARDS, best position can be life saving for this decision, prone position. Improve oxygenation, improve compliance, reduce willy, reduce mortality. Remember, prone early, prone long, protect lung, and save the lives. Thank you. I am Dr. Bhautik. See you in the next lecture, where we will discuss the neuromuscular blockage in ARDS. When, why, and how long. Thank you.